All right, everybody. Hello, hello. I hope everyone's doing well. We're going to get started soon. Okay. So don't mind me, guys. I have both Instagram going. Hi, everybody. Hope everyone's doing well. So I have Instagram going, and I also have uh, the computer going. So don't mind me. So just going to give everybody a few minutes. Or not so much minutes, but all right. All right, guys. We're going to get started in a second. Just want to give everybody some time to get on. Okay, come on in, guys. Trying to figure out why Facebook isn't working with me right now. Not sure what's going on with Facebook. Okie dokie. Wondering if the time is different. All right, we're going to get started in a second. All right. Alrighty, guys. So we're going to go ahead and get started. So I am now live. I apologize for the delay. Hi, everybody. My name is Damaris Edmay. I am the CEO, co-owner, and tutor, one of the tutors for Edmay Nursing Tutoring LLC. Our is to educate, empower, and mentor the next generation of nurses. And the way we do that is by closing the gaps in knowledge and also increasing students' self-confidence so that you can be competent, confident, and knowledgeable nurses. And so, one of these things, in order for you to get to that point of becoming a successful nurse, is passing your NCLEX. And so, that's what today's video is on. That's what our live is for today, is to go over some tips and tricks to answer those tough questions. And today's focus is on priority questions and legal questions. Okay. The other thing I want you guys to keep in mind is that a lot of the tips and tricks for the NCLEX is really based on the question itself. So I want you guys to keep that in mind, that when you're answering questions, when people give you some suggestions on how to answer the question strategically, not every single tip and trick is going to work for every single question. So everything I give you, you can apply to just about any question that's based on priority or legal, but it doesn't mean that that's going to be always work depending on what the question is asking you. And I'll give some examples. But before I go further, in case you guys don't know who I am, again, my name is Damaris. I do have a master's in nursing education, which is my passion. I do currently teach bachelor's nursing students currently who are going for their degree in nursing. So I teach BSN nurses. And I do have a background in cardiac step down. And so that's where I first started. I did the nurse residency program when I first started as a nurse. And then I did that for about a year or two. And then I moved on to population health nursing, where I learned so much, especially in patient education, preventing readmissions, discharge planning, transitional care, and just really ensuring that I treat the patient holistically once they get to the home setting. So, hey, Latoya, thanks for joining, love. So that's just a little bit about me. And then after a few years of doing that, I decided to pursue my degree in nursing education. I had a passion for it for a very long time, even from nursing school time, first semester. And I told my husband, I'm like, you know what? I want to do this. Let's do this. I had a 6 month old at the time. He's now about to be 3 this year. It's crazy how time flies. So I'm just really excited about all that God's doing in my life. But without further ado, let's get into these tips and tricks. I hope you guys brought your notebooks, your pens and paper to take these notes. Again, we're going to be going over some tips and tricks for like those priority questions and those legal ethical questions. All right. So the first topic, and it won't be long, I promise, because I know some of you guys got to get back to studying. But one of the first things is when you're having a question about a patient leaving against medical advice, or in other words, AMA. So NCLEX has incorporated these questions now. I didn't really have these questions when I took my NCLEX, but now those are some questions that are coming up because this next generation of nurses, which are you all, have to know these legal things. And they noticed that there was a gap in knowledge about what to do ethically for these patients and legally. So you do need to know the legal aspect of your role as a nurse, because it can affect you when you're practicing and you're not practicing according to the law. And of course, everything is different depending on the state that you're in. But if you have a compact license, for the most part, it's a kind of standard if you have a e-compact license like myself and my husband. But but regardless, I would still go and ask if you're doing travel nursing or you're not based in Florida like I am. Definitely look up your legal obligation as a nurse, because every state has different laws that must be followed as a nurse. However, AMA is across the board. A patient leaving AMA is across the board. So they're going to ask you questions that's either who can leave against AMA or who cannot leave AMA. So who can leave, right? Anyone who is mentally capable, they are able to leave, even if they cannot verbalize to you, but they can shake their head yes or no. They can write something down. They can blink their eyes. They can, do a finger thing, whatever. If they are mentally capable, okay, and they have not been deemed mentally incapacitated, even if it is life threatening, okay, guys, yes, they can leave. All right. So a lot of people get tripped up on questions like that, right? Because they think that, oh, well, a patient, they just got told that that they have a STEMI, and they're saying, oh, I want to go home, right? Guess what? And yes, that's a question. Guess what? That person can leave. Even though that MI can kill them, that heart attack can kill them, they can leave. Okay. So if they're mentally capable of making decisions for themselves, even if it's life threatening, yes, they can leave. Okay. Now, who cannot leave? And Latoya, thank you. You're already on board with me, girl. Yes, anyone who is on a psychiatric hold, okay, or Baker acted, cannot leave AMA. Okay. It doesn't matter if they are completely with it. Legally, they are bound to that 72-hour hold. Okay. Some states do 5 days, some states do 3, some states do 2. So find out what's your state's requirement. However, it is typically that 72 hours. It's typically a 72-hour hold. Also, anyone who has altered mental status. Okay. So if they come in and they're confused because they have a UTI, right? And they're saying they want to leave, but they're extremely confused and they think that they're at their grandmama's house and not in the hospital, that person cannot leave AMA. Okay. Who else cannot leave? Anyone who has a mental illness and they are in an active psychosis or manic phase, or they're depressed and having suicidal ideations. Okay. Also, anyone who has any kind of hallucinations or delusions, especially if the hallucinations, the voices that they're hearing, especially if those hallucinations are telling them to harm themselves or someone else, okay, they cannot leave. All right. Also, anyone who is under the influence, whether that is someone on drugs or alcohol or any kind of substance that's altering their mental status, anyone under the influence cannot leave AMA. So if you get a alcohol withdrawal patient or opioid withdrawal patient or whomever patient who's withdrawing, or they're under the influence some sort of drug or chemical, they cannot leave. Okay, legally they cannot leave. And then finally, anyone who is at risk for harming themselves or others, which I already said, right? So if that person is going to harm themselves or that person's going to harm someone else, they cannot leave. Okay, so they're not allowed to leave, legally speaking. So when you're answering these questions, NCLEX will throw you a question like, you have 4 patients that all want to leave AMA, right? Who will not be allowed to leave AMA? Select one or select all that apply, right? Because NCLEX loves the select alls, right? And you have to make sure that you know the difference between who can leave and who cannot leave. Okay. So for example, this was a question that one of my students had where they got this question wrong because they didn't know that someone who is actively having a heart attack or someone who is literally dying from something, right? Or it's life threatening, if they are mentally there, they can leave, right? So they picked someone that couldn't leave, right? Which was someone who was under the influence, right? So that was the person they picked. They picked somebody who was having alcohol withdrawal who said that they want to go home, right? That person cannot leave. But the person who's having an active MI, active heart attack, and they're saying, I want to go home, give me that paper to sign, they can leave. All right. Now, what about parents? Parents can leave AMA with their children. However, the only time that parents cannot leave AMA is if they're refusing limb, life, or organ saving treatment for their child or their minor. Okay, even if it goes against their personal beliefs. If they're trying to leave because, oh, I don't believe in this or whatever, and it's going to harm the child or the child is going to die from it, they are not allowed to leave AMA. And legally, we can treat that child against the parents' wishes. Okay. So there's a thin line, ethically speaking and legally speaking. So we have to be very careful and we have to make sure that we are having these interdisciplinary meetings to discuss the case. But NCLEX is going to ask you, right, a question that says, that the child needs, this particular medication and the parent, this particular antibiotic for an infection, right? Let's just say the child has meningitis and they need antibiotics for it, but the parent doesn't believe in antibiotic treatment. That parent is saying they want to go home and is asking you as a nurse, what do? You do not let that parent leave. Okay. That parent cannot leave regardless of how they feel. Okay. So again, the parent cannot refuse anything that is life-saving, whether it's a limb or organ or something for treatment. Okay. If it's going to save the child's life, they cannot leave. All right. So I hope you guys took those notes. The next thing I wanted to discuss is the priority versus first questions, right? So NCLEX will ask you, what is the priority for this patient? Or they'll ask you, what is the first thing to do? Okay. So that trips a lot of people up because sometimes we think that the first thing is always the priority, but that's not the case. Okay. The priority thing can sometimes be the first thing you do, but that doesn't mean that it's always the first thing you do. All right. So priority does not always mean first. Okay. Priority is the general picture. What is the underlying problem? And what do you have to prioritize in general? Right. So if it asks you a priority question on a patient who's hemorrhaging and you decide to put an IV in versus, stopping the bleed and holding it and applying pressure, right? Which one's going to kill the person first? Putting the IV in or stopping the bleed, right? The priority is to stop that bleeding, right? So that's the difference, right? So you have a priority, which is the person's going to bleed out if I don't stop the bleeding. But that doesn't mean that you don't put the IV in, but the IV wouldn't always be, but the IV may not be the first thing you do, right? The first thing and the priority thing to do is to stop that bleeding. But sometimes the first thing to do is to put that IV in, even though the priority is to stop the bleeding. So it just all depends on the question. So make sure you read the question carefully. Anytime they give you that question, they give you certain things about the patient and they tell you things you need to know in order to answer the question appropriately. All right. So make sure that you actually look at the question and read it, especially that last part of the question, which is typically the actual question, right? What is the priority or what is the first thing to do? All right. So the first thing does not always have to be the priority. All right. So if it's asking you a first question, it's not just priority, right? Sometimes it's just what's the first thing you do, right? You have a patient who has an MI, right? The priority is to lower or decrease the demand, the oxygen consumption demand of the heart, right? We don't want to cause the heart to pump harder or to work harder than it needs to because it's actively injured, right? But the first thing you want to do is probably get an EKG, right? So they might ask you, what's the priority? Decrease demand. But then they ask you, what's the first thing to do? Get that EKG, right? Or Mona or whatever. Whatever. You have to read the answers and determine based off of the answers because it could be multiple things, but they only give you answers in that question that you can pick from. So always look for the first thing to do versus the priority and make sure that you pay attention to those words and they sometimes bold it for you because they wouldn't put two different words if there wasn't something to focus on, right? So if it says priority, what's the priority for this condition for this patient? If it says first, what's the first thing you're going to do for this patient, right? Don't confuse the two. Yes, sometimes priority is the first thing and yes, sometimes the first thing is the priority, but not always. So make sure you read the question carefully and that you understand and you look at the answers, all right? Look at the answers. And I always tell my students to always ask yourself, what will kill, harm, or put this patient at risk or jeopardize their safety? Okay. And that also goes for protecting yourself as a nurse, protecting the staff, and protecting visitors. Okay. That is also priority. Okay. So if you have a patient who has TB, right? And it says, what's the first thing to do? And yes, that's a question and you choose between getting a set of vitals versus putting the sign on the door that this is an airborne disease going on, the first thing you want to do is put that sign, right? You want to protect everyone, yourself, visitors, and other staff, including the patient, right? That is considered a priority. Safety for the client and safety for everyone else. All right. But just always keep in mind what will kill, harm, or put the patient at risk for any type of injury or safety issues. Okay. And that does include you as a nurse being safe for yourself. Okay. And other people around you. So always think priority is patient safety, life saving measures. Okay. Always know priority will always be based on life saving measures and treating the root of the problem, not the symptom, the root. Okay. Now let's jump into healthcare proxies. So a lot of people are not aware. This was a question, and I thought this was a great question. It said, the question had said, right, that the patient is unable to make decisions for themselves, right? And it's asking you, who would you go to get consent? All right. My student had picked the spouse. But what they didn't realize is that one of the answers said healthcare proxy or healthcare surrogate. The answer was healthcare surrogate or healthcare proxy, not the spouse. And then the student asks, "What? I thought the spouse was the, decision maker." Technically, no. So if they have stated or legally have a document which is considered the advance directive, if they have an advance directive and it legally states the person's name, or if they verbalize to you a person's name, and this is why it's so important as nurses, when you do your admission, you always ask the patient, do you have your advance directive? And if you don't have an advance directive, who is your healthcare surrogate? And also confirming that if they have that advance directive, if that person, if it's current, Is the person listed still your healthcare surrogate? Okay. If the patient can tell you that, you better follow it. All right. So, for example, this is a personal experience. I had a patient who he was going for a scheduled a scheduled open heart surgery, right? And he he had a aide that had lived with him and his an in-house aide who had lived with him and his wife for many years, for over a decade. Okay. And she technically was the wife. She was the aide for the wife because the wife had some mental issues, right? And he specifically stated, you can tell her anything. You can update her on anything. Well, lo and behold, the patient suffered some complications, right? And his son was listed as the surrogate. So the staff, because he had said to us that we could speak to the aide, the staff was talking to her when the son wasn't around. Well, guess what? The son got mad and he said, I'm the healthcare surrogate. Why are you asking her, about decisions? I'm the one that's supposed to be making the decisions. And he was absolutely right. However, good thing I documented that the patient gave us permission to incorporate the aide into his decision making, right? So if the son wasn't available, he gave us the right to speak to her as well. All right. And so legally, we covered ourselves, okay, because the patient verbalized it, it was documented. And even though his legal advance directive said that his son is the decision maker, which his son is still the decision maker, we still were allowed to give medical updates to the aide. All right. So always make sure when you're at the bedside that you're checking that stuff out. But also on NCLEX, they don't include all that confusion in there because that's just confusing stuff. They ask you straight to the point. Who do you go to first? Always pick the answer that says healthcare proxy or healthcare surrogate. That is always your first person to go to. Now, you're asking, I thought it was always a spouse. No, it depends on who it is. Okay, it's not always the spouse. Believe it or not, you could have a spouse. The person could have a spouse, but they could have listed their child as the healthcare surrogate, or their sister, or their brother, or whomever. So the healthcare surrogate doesn't always have to be a family member, all right, or a spouse. However, let's say, and the only time that you activate the surrogate is when the person is mentally incapacitated. So they are incapable of making medical decisions for themselves. Okay. So like a good question, another good question that we came across with my student the other day was, it said, that the patient signed for only one surgery, right? They consented to one surgery. But when the surgeon got into the surgery, they found other things that needed to be addressed surgically. And so it asked you as a nurse, what were you supposed to do in that situation? The answer was that you were supposed to wait and talk to the patient about it, because the patient was mentally capable of making their decision, right, when they signed the consent. So you had to go and you had to wait until you speak to the patient to see if they want to address this at a later time. Okay. Or the question could say, the patient is not able to make decisions for themselves, and that the next of kin is available. Let me, should you ask the next of kin? No, because the patient may not agree to that, right? The patient may not agree to those decisions that the person's making, right? So the person may say, yeah, take out the bowels, right? But the patient might have said, no, I want my bowels. I don't want a stoma. I don't want an ostomy, right? So you have to, if the patient can make decisions for themselves, you ask them, okay? If they are not able to make decisions for themselves, they're mentally unable to make that decision, then you would go to the healthcare proxy. So then you ask, well, when do you talk to the spouse then, or the kids? Glad you asked. You always go to the person who was legally documented first, but if that document is not available, then you go to the next of kin. Okay? You go to the next of kin. Who is the next of kin? Well, obviously, legally is the spouse. The spouse is the next of kin. Then if there's no spouse, you go to the children. If there's no children, you go to the siblings, you go to, and you keep going down the list until you find someone, okay? Until you find someone. So this is why it's important that you always ask your patients, do you have an advance directive? And if God forbid you can't make decisions for yourself, who can we call on? And you always ask them for at least two people, because there was times when I was working where when I was working in population health, where the healthcare surrogate was mentally incapacitated as well as the patient, and the patient didn't list anyone else. So we were forced to ask a niece, you know. I mean, we didn't have a choice, you know, and so that does happen. So the next of kin always starts with a spouse, the children, and then family members of that person, and then so on and so forth until you find somebody who agrees. All right. And Latoya, yes, thank you so much. She said because they only agreed to that specific surgery, the surgeon has to wait until the patient is fully awake, alert, and oriented ×4 to make sure that the patient would want that done. Absolutely. Thank you so much, Latoya. Awesome input. So now let's talk about vented patients, because we like to assume that vented patients are mentally incapacitated. That's not always true. Vented patients, or patients that are mute, meaning that they are unable to speak, does not mean that they are deemed mentally incapacitated. They can still verbalize or non-verbally express their wishes. So there was a question that said, you know, patients vented, you know, and they need some sort of procedure done, right? Who do you go? What do you do next as a nurse? And the answer was between ask their healthcare surrogate or ask the patient to write it down, because the patient was able to write. Well, my student picked ask the healthcare surrogate. That was the wrong answer. Why? Because the patient was still able to make decisions for themselves. So just because someone's vented does not mean you cannot ask them their wishes. You better ask them their wishes, because legally, when that vent comes off, they coming after you if you go against their wishes, okay? So always think, is this patient capable of making decisions regardless if they can speak or not? Okay? And if you question someone's mental ability to make medical decisions for themselves, informed consent, you need to get a psych consult to determine if they are deemed mentally capable of making decisions for themselves. Okay. That psych consult they will evaluate them and determine whether or not the patient can make decisions for themselves, or if you have to go through their next of kin or a healthcare surrogate. All right. Again, um, the healthcare proxy is not always the spouse, and it's not always or it's not always children or family members. Okay. There are some people who their best friend is their decision maker, even though they got a husband and 10 kids, right? Because you want someone who you know is going to respect your wishes. All right. So always keep that in mind. All right. And that goes for all of you guys too. If you don't already have a decision maker for yourself, if God forbid you can't make decisions for yourself, I suggest you do that ASAP. All right. COVID made it very evident that it doesn't matter how old you are. If you, God forbid, cannot make decisions for yourself, you better find somebody that is willing and able, and that they are aware that you chose them to make decisions for them. Okay. Because I've had that happen sometimes, where we would call somebody because they were listed as the healthcare surrogate, and the person would say, I didn't agree to this. I didn't agree to this. And I'm like, oh boy, right? Because the person didn't tell them. All right. So make sure that you have that conversation before selecting your healthcare surrogate. All right, guys. So the phone's dying. Forgive me. I have to turn it sideways. All right. So advanced directives. All right. Before going to the healthcare surrogate, always ask, is the patient able to make decisions or not? All right. So don't be so quick to jump straight to the healthcare surrogate. All right. So you use the advanced directive only if the patient cannot verbalize their wishes. That's when you go to that advanced directive. So what about, let's jump to transferring patients. All right. So you have patients on the unit, and you need to make room for new patients that need to be admitted, that are appropriately supposed to be admitted to your unit, but your unit's full. So now you got to transfer them out. So now NCLEX asks you, who can you transfer off the unit? Of course, pay attention to the kind of unit that they ask you about, right? Because some people, they don't pay attention to the unit and they just kind of just pick any old person. But pay attention to the unit. If it's a cardiac unit, all right, you better make sure that you're not transferring out a patient who is not cardiovascular, hemodynamically stable. All right. And make sure that that person doesn't have any upcoming surgeries, or they're not on any medication that requires them to still be on the unit at that level of care. Okay. So Always pay attention to the kind of unit that person's on, first and foremost. All right. But also look for any, when you're actually going to transfer someone out, always look for the person who is the most stable, terminal, or so sick that they're going to die, or palliative end of life, right? And they're ready for discharge. Okay. So there was a question about a patient, there's 4 patients, and you have to decide who has to be transferred out. All right. And one of the answers was somebody going for open heart surgery tomorrow. The other one was somebody who was on a cardizem drip or diltiazem drip, right, for AFib. And then someone who is actively having an MI, all right, actively having an MI. And then it said someone who has end stage CHF and the family decided on palliative care. Who do you think really is going to be the one transferred out? Yes, the palliative care terminal patient. Everyone else is appropriate to be on that unit, right? And yes, that was another question that was a trip up for my student, because they were like, "What in the world?" Like, I didn't know. Like, I thought that person needed to be there because they have end stage CHF. They do, but the person is terminally ill. They've decided to take comfort measures. They no longer want aggressive treatment, and there's nothing more to be done. So now that person needs to be transferred to admit that new person from the ED. All right. Um, let's talk about floating, okay? Because those floating questions trip people up too. So you'll get questions that says that you L&D nurse. By the way, this doesn't really happen in real life, and if it does, I'm floored. Okay, but an L&D nurse gets floated to the ICU unit. Why? I have no idea, but this was a question. The person gets admitted, gets floated to the ICU unit, right? And you have to choose what is the appropriate assignment for that person. Okay. Now, you have to think about what does that person do on a daily basis versus what does the unit deal with on a daily basis. So you kind of have to know what an L&D nurse does versus what an ICU nurse does. Okay. So the question was such a great question because it was saying that, there was a patient who had sickle cell and they needed like around the clock morphine versus a person who's hemodynamically unstable because they're hemorrhaging, right? Which one do you really think that the L&D nurse is used to dealing with? If you picked the hemorrhaging patient, you are correct. If you picked the sickle cell patient, you are incorrect. Why? Because they don't deal, L&D doesn't deal with sickle cell patients. They don't know what to do with sickle cell patients per NCLEX, okay? They don't know, they don't deal with people with sickle cell on a daily basis, right? But they do deal with people hemorrhaging on a daily basis. So that would be the most appropriate person to give them in the ICU is a person who is hemorrhaging, right? The same would go. There was another question about a PEDS patient, a PEDS nurse who got floated to the adult med surg unit, right? So you have a PEDS nurse and they're being floated to an adult med surg unit. And I'm not giving you guys the other two answers because you have to learn to eliminate, right? So it was asking who would be most appropriate to give to this PEDS nurse on an adult med surg unit. A person who was diagnosed with type 2 diabetes and needs discharge instructions versus someone who has a sickle cell crisis, right? Who do you think would be most appropriate for that PEDS nurse? The sickle cell patient. Why? Because sickle cell crisis starts in the youth, starts in the young person, starts in the PEDS population. So they are so used to dealing with these sickle cell crisis because these kids are coming in and out all the time. So giving them that adult who has had sickle cell since they were a child is the most appropriate versus someone who has type 2 diabetes. They deal more with type 1 diabetes patients, not type 2. Although type 2 is slightly increasing in the not slightly, significantly increasing in the pediatric population because of diet and lack of exercise, etc. But the most appropriate person that you should give is the sickle cell, not the type 2 diabetes, because the type 2 diabetes is not common in the pediatric population. That's more so common in the adult population. All right. And also, children don't have a choice in what they eat per se, right? For the most part. NCLEX world, right? They eat what the parents give them, okay? So, whereas the type 2 diabetes adult, it was probably due to their eating habits, right? So, that's a very hard and difficult thing per NCLEX for a pediatric nurse to deal with versus a sickle cell crisis, right? They're used to that. All right. Now let's talk about reporting abuse. All right. We're almost done, guys. So let's talk about reporting abuse. Anytime you get a question telling you as a nurse that you have suspicion that somebody's being abused, NCLEX wants to know, are you going to report it? So there was a question that said that the nurse was suspicious that that a child was being abused, and it said, what should the nurse do? One of them said obviously to report it, right? The other one said to not report it because the physician said that they don't believe that the person's being abused. And then another one was saying that the parent denies denies any abuse. Guess what the answer was? If you said reporting it anyway, you were correct. All right. So just because the parent denies it, the child denies it, the physician denies it, administration denies it, nurse manager denies it, it doesn't matter what anyone says. If you as a nurse have any suspicion that someone is being abused, whether it's a child, an adult, or an elderly person, you have a legal obligation to report that. I don't give three craps if Dr. So-and-so said you better not report that. I don't give three craps if your nurse manager says, I'm going to fire you if you report it. I have a legal obligation. My license is not connected to you. It's connected to the state, and I can lose my license for not reporting that. Okay. Because if that person ends up dead because I didn't report it and protect them, right? Because remember, patient safety, right? Client safety is the number one thing in nursing. If I don't report that, that's my license. My license go bye-bye and I lose my job altogether, right? So it doesn't matter what anyone says, even if they're denying the abuse, you have to report it. So always pick the answer that says report it anyway, okay? Report it, report it, report it, okay? Report, okay? And yes, Latoya, you better follow your instincts, okay? You know your patient. You were with them for that 12 hours and sometimes multiple days back to back, okay? So you know whether or not that you have that instinct. That's what we call nursing instinct and nursing intuition. Something in you just doesn't seem right. And this is such a big issue that they make it mandatory when you go to renew your license to know what abuse looks like so that you can report it. All right. So I hope that you report it. Yes, it's hard. Yes, it sucks. Yes, you probably may not be right. It doesn't matter because that one time that you are right, you just saved a life. All right. So always report. Per NCLEX, you always report. Okay. And finally, let's talk about life-threatening situations, about prioritizing life-threatening situations. Some life-threatening situations that you need to prioritize is if anyone has a deviated trachea. Okay. If anyone on your list that says who would you prioritize as a nurse out of all your lists of patients, if you see deviated trachea, that better be your first patient you go to. Okay, the minute you see the trachea go boop, that you got a short time span to deal with that patient before they die. Okay, that is a medical emergency. That is a life-threatening emergency, and that indicates that there's a potential tension pneumothorax happening. So that person is typically the person that gets the needle stuck in the chest. Y'all might see that in the shows and stuff like that. They stick a needle in the chest to release the air to reinflate the lung to bring back the trachea so it doesn't obstruct airway, right? And then that person needs to be followed up with a chest tube after that. All right. So anytime you see deviated trachea, better pick that patient. Okay. Another one is status asthmaticus. The minute you see a patient who has status asthmaticus, silent chest or something like that. I think the other name for it is like silent chest. That better be a top priority. So if a person is wheezing and all of a sudden they go silent, you better run to that patient's room, okay? Because that patient probably stopped breathing or their airway is obstructed, and that's a code. All right, that's an immediate code. So anytime you see a status asthmaticus patient as your choice, as one of your answer choices, you better pick that one, okay? Especially the person who's at greatest risk for status asthmaticus, okay? And this is why asthma is such a big deal. I know like we kind of downplay asthma these days because, oh, just take your inhaler or take a nebulizer or take a steroid or whatever. But their airway can become obstructed. That right there can kill them. Okay. So never take it lightly when someone comes in with an asthma attack. Okay. They literally cannot breathe. All right. So always, always, always make sure you pay attention to your asthma patients. But if they are a status asthmaticus, you better prioritize them. All right. Now, if they're a stable asthma patient, all right, you don't have to prioritize them. However, if they go into status asthmaticus, you better prioritize them. All right. Liver biopsy patients. Anytime a patient goes for liver biopsy, what's the number one thing they are at greatest risk for? And NCLEX loves asking these kinds of questions. If you said bleeding, you are correct. Why? Because the liver is highly vascular. Okay. That and also the spleen. Anytime you see that a patient's at risk for a ruptured spleen or that they have a liver biopsy, your number one thing to prioritize is a risk for bleed or hemorrhaging. Okay, that can literally kill them. All right. So you always got to look for the signs and symptoms of a patient who is experiencing hemorrhaging, all right, or who's experiencing signs and symptoms of bleeding, all right, especially post liver biopsy. Another one is orthopedic patients who had surgery or a fracture. Okay. They are at greatest risk for what? Ding, ding, ding. Pulmonary embolisms. Okay. So anytime you have an orthopedic patient and all of a sudden their respiratory status is depressed and they are starting to be, their respiratory status is compromised, you better run in that room because they probably threw a PE and there's a potential of them dying. Okay. So always be on edge about your orthopedic patients when you're taking the NCLEX. They're always at greatest risk for a PE. All right. So always look for the signs and symptoms of PE. Now, blunt head trauma patients. Why do we freak out about these patients? Okay. These patients have an increase in ICP or increase in intracranial pressure. Okay. Anytime you have an increase in ICP, it is never a good thing. Okay. Especially for any blunt head trauma patients because they have what we call a slow bleed, meaning that they, even though they hit their head, they're still bleeding and that bleeding didn't stop. So these patients don't usually present with any life-threatening symptoms until about 48 to 24 to 48 hours after the trauma. So these patients need to be monitored very closely within the first 1 to 3 days. Okay, within the first 24 to, I'd say, 72 hours. Okay, because if it's not addressed, that intracranial pressure will increase and it will continue to increase and eventually it'll herniate the brain. And the minute that the brain herniates, that person is brain dead. So some of the things that you know that the ICP is increasing is that they start to have projectile vomiting, they have pupil dilation, and they end up with seizures. Okay, so if you see any of those signs, all right, and it's a patient who had a head trauma or they hurt their head or they fell and hit their head or any kind of head injury, and all of a sudden they're projectile vomiting or their pupils are dilated or they're seizing, that person probably has a blunt head trauma, a slow bleed, their ICP is increasing, and their brain is about to herniate. So this is life threatening because they could end up brain dead. So you better get on that patient. Again, projectile vomiting, pupil dilation, and seizures. Anytime you see that, that means that there's a blunt head trauma and there's an increase in ICP. And then lastly, infants. One of the most dangerous things for infants is when they become dehydrated and have electrolyte imbalances. Why? Because infants, their body weight is 70 to 80% of their actual fat. I mean, of their actual body weight. 70 to 80% is water or fluid. Okay. So the minute they get dehydrated, that is a big no-no. Okay. That's why they always tell you, like, if the child is not eating or drinking or they're constantly vomiting and having diarrhea and they're lethargic and, they're fatigued all the time and blah, 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 you got to bring them in. Or they're having persistent fevers and they're not drinking anything or they're constantly vomiting and diarrhea, you better bring them in because their body is predominantly fluid. Okay. It is straight fluid. And if we don't replenish those electrolytes, they're going to have a serious heart cardiac arrhythmias, which can be lethal, such as VTAC, VFib, right? Torsades, depending on what kind of electrolytes they're losing, right? But also that baby is going to be so dehydrated that they don't have their bodies are so small that they need that volume to pump blood, right? And so if they're not getting that blood pumping, that child is going to die, right? So it is a medical emergency when an infant is constantly dehydrated, vomiting, diarrhea, and it's nonstop, and they're not having any oral intake. That child needs IV hydration. All right. They need IV hydration. So they need to be brought in immediately, and you need to prioritize those children. And then one last bonus tip. I know you guys know the word ABC, right? Airway, breathing, circulation. We hear this, it's drilled in our heads since day one of nursing school. However, NCLEX is a little different, okay? So you always try to apply ABC to your priority patients, okay? Or first patients, right? So if it gives you you get an assignment and it asks you who to prioritize or who's first that you should see, always apply the ABC to each and every patient. Say, is this an airway issue? Is this a breathing issue? Is this a circulation issue? Okay? And it's in that order, okay? Unless it's CPR based, then you would do circulation, airway and breathing, or CAB. Okay. So if it's regular priority, there's no CPR involved, ABC. If there is CPR involved, you change it and you do CAB or CAB. Okay. Circulation, airway, and breathing. Some answers may have more than one of those three things. So if you're going down the list and you see that the person has both airway and circulation, but then another person just has breathing, you better prioritize the person that has more than one. Okay? Prioritize that patient who's hypotensive and their oxygen saturation is dropping versus the person who, their respiratory rate dropped to 10, right? The person you need to prioritize is that hypotensive patient whose oxygen saturation is dropping, okay? Because they're going to code, all right? So you always prioritize the person who has more than one. And always remember that it depends on the question. Not every question is airway and breathing the first option. Always ask yourself, is this expected and or is this person stable? Okay, so if you have a COPDer who is sitting 89% on 2 liters of oxygen versus a person whose blood pressure is 70/40, guess who takes precedence? The 70/40 blood pressure, right? So it depends on the question, all right? Who is the most unstable or who is the first to die? Is what you got to ask yourself. If I don't go address this now, who's going to code? Who's going to die? Who is the most unstable? All right. Then, if ABC is not applied to your question, if you can't apply it to your question, then you prioritize infection and pain. Okay. Why? Some infection is life-threatening. So if a person is becoming septic, that's life-threatening because they can go into multi-organ failure and that will end up causing them to die. All right. So infections you prioritize, all right, especially if the person's unstable. All right. So they don't always prioritize like a WBC of 15. You know what I'm saying? They always give you a little more to that infection. All right. So always, if they give you more details into the infection, that's the one you deal with. All right. Especially if the person sounds unstable with that infection. All right. And then pain. Pain can sometimes be life threatening depending on what it is. So if you're having pain on your left side, okay, there is a potential that you have a spleen that is ruptured, right? Because remember, usually we say pain is not priority, which is true, unless it is potentially life threatening, meaning this person may have some, because remember, pain is telling you that something's wrong. Okay. That's what pain tells us. It's that something's wrong, something's out of order. So when you get a pain patient as one of your answer choices, ask yourself, is this pain expected? Is this pain stable? Right? And is it life threatening? Okay. So, for example, there was a question about a patient who had infectious mono, right? And The person was like day 10 from being infected with mono. Okay. And they said, okay, the person has mono and they're complaining about pain in their right side, right? They're complaining about pain in their left quadrant, right? They were complaining of left quadrant pain, right? Versus somebody who had a fever and that was it. They just had a fever and and they're coughing. Who would you prioritize, right? The person that you would prioritize, you would think initially, because it's, especially when they're children, you think, oh, well, the child that has a fever and they're coughing, that's who we should prioritize. But really, you should prioritize that mono patient who's 10 days in, because when not treated properly, their spleen can rupture, and that is a medical and life-threatening emergency because of hemorrhaging. All right. So, once again, these are all tips and tricks for you guys when you're answering priority and legal questions. My name is Damaris. I'm so glad you guys joined us. For this session. I hope you guys took notes. All right, this is going to only help you succeed in Excel. And these tips are things that I've seen like consistently. So I'm not just telling you because, oh, well, it was just one question. No, I've seen these things in multiple questions, and these things helped the person to answer the question appropriately. All right. So if you're ever interested, my name is Damaris. I am the CEO, co-owner, and one of the tutors of EdMe Nursing Tutoring. If you want to check us out on our website, it's called EdMe Tutoring, edmetutoring.com. You can always email us at edmetutoring@gmail. You can always reach out to us via phone at 754-272-7232. And you can follow us on all social media platforms, Facebook, Instagram, and YouTube. Don't forget to hit subscribe, like, and if you have any questions, please don't hesitate to reach out to us. We're more than happy. We provide free consultations to our to new and potential clients to discuss and to determine your needs and study habits so that we can come up with a plan for you to be successful, not only in nursing school, but also when you're studying for your boards. If you're interested in becoming a nurse, or you're a brand new nurse, or you are a nurse looking to change careers and or change specialty, and you're looking for someone to mentor you, we offer mentoring services. And if you're a student who's struggling with writing papers, everyone's favorite, and you are like, man, I am not an APA guru and I need help, we offer that as well. All right. So thank you guys so much. I hope this was helpful, and I hope this was insightful. I hope you guys took notes, and I appreciate you guys for joining. Latoya, I love you. Mwah. Thank you so much. May God bless you all. See you guys next time.